coronary blood flow and ischemic heart disease. So this is just a recap of your coronary anatomy. So you already know this. You have two main coronary arteries coming off from your ascending aorta, specifically the aortic sinuses. So the left circulation would be the left main coronary branching into the left anterior descending and the left circumflex. And you have only one right coronary. This is how your coronaries would look like in a coronary angiography. So this is your right coronary artery. This is your left anterior descending. This is the left circumflex, and this is your left main coronary. So it's kind of a very short branch. So the normal coronary blood flow in the resting human heart averages 70 ml per minute per 100 grams of heart weight. That is about 225 mLs per minute, which is equivalent to 4 to 5% of your total cardiac output. So this is the physiologic anatomy of your coronary vessels. So the physiologic basic changes of your coronary blood flow during cardiac cycle, wherein during systole, your blood flow through the subendocardial plexus of your left ventricle is reduced because of the intramuscular compression of the of your subendocardial myocardial vessels. So most of your coronary blood flow happens during diastole, and it has the lowest coronary perfusion during systole. So what are the controllers of your coronary blood flow? So your local tissue metabolism is your primary controller. So in response also to your nutritional needs of the cardiac muscle, your coronaries the response would be local arteriolar vasodilatation. And then other controllers would be oxygen demand as well as nervous control. So like I said, your tissue metabolism is your primary controller. The primary response would be local arteriolar vasodilatation in response to nutritional needs of your cardiac muscle. The second control would be, when you talk about oxygen demand, so if you have, let's say, decreased oxygen concentration in your heart in hypoxemia, this would cause arteriolar vasodilatation by release of your potent vasodilatory substances like your adenosine, which is a very potent vasodilator. You also have release of your adenosine phosphate compounds, potassium ions, hydrogen ions, carbon dioxide, prostaglandin, and nitric oxide. So these will all promote coronary arteriolar vasodilatation. The direct effects of your nervous control result from the action of your nervous transmitter substances like acetylcholine from your vagus nerves and norepinephrine from the sympathetic nerves on the coronary vessels. The indirect effects result from secondary changes in coronary blood flow caused by increased or decrease in activity of your heart. So nervous control causes vasodilatation via direct effects from your sympathetic, that is the action of your acetylcholine from your vagus. So what is ischemic heart disease? So ischemic heart disease is the same as coronary artery disease. Now, calling it coronary artery disease lang, it connotes the anatomic description of the disease. So what is IHD or CAD? It's basically a blockage or narrowing or stenosis of your coronary artery or arteries that supply blood to the heart muscle, causing decreased supply of oxygen and other nutrients inadequate to meet the cardiac metabolic needs. So there are many risk factors for the development of atherosclerosis, which is the most frequent cause of coronary obstruction. So the risk factors are either your non-modifiable risk factors, like your genetic predisposition, you cannot modify that, and your modifiable risk factors like your lifestyle, your weight, as well as the development of hypertension, which is both a component of modifiable and non-modifiable. So in atherosclerosis, there is large quantities of cholesterol gradually becoming deposited beneath your endothelium at many points in your arteries throughout the body. Okay, so atherosclerosis is a systemic disease. The net result is the development of your atherosclerotic plaques that block or partially block your blood flow. A common site of development of your atherosclerotic plaques is the first few centimeters of your major coronary arteries. Again, your atherosclerosis is a systemic disease. It has a predilection specifically to your coronary arteries. So what happens during the development, or how does your atherosclerotic plaques develop? So first, that part of the figure labeled 1, there is attachment of your monocyte to an adhesion molecule on a damaged endothelial cell of an artery. And then this monocyte migrates through the endothelium into the intimal layer of your arterial wall and is transformed into a macrophage. And then this macrophage then ingests and oxidizes lipoprotein molecules, becoming then a foam cell. This one. And then the foam cell releases substances that cause inflammation and growth of your intimal layer. So the figure in your right shows the additional accumulation of your macrophages and growth of the intima that causes your plaque to grow larger and accumulate more lipids. Eventually, the plaque may occlude your the lumen of your vessel, or they may rupture, thus causing blood in the artery to coagulate and form a thrombus. No, that is the physiology of myocardial infarction, which we will discuss later on. So this is how your plaque looks like in a histologic section versus your gross section. So if you look at it, this is your narrowed coronary artery lumen, and this is your plaque obstructing the lumen. So the growth is inwards towards the lumen. And the most vulnerable part of your plaque is the cap. This is the fibrous cap. This is the one that ruptures during an infarction. So actually, ischemic heart disease is not just a single disease, no, but it is a spectrum of clinical disorders, usually reflecting the stages of atherosclerotic burden of the coronary arteries. So what are the spectrum of IHD? So first, you have stable IHD, or we call this stable angina pectoris. It just means that your coronary plaque in this stage is like minimally obstructing only, usually causing symptoms only during periods of increased cardiac demands. And then for the more progressive types of plaques or the more severe obstructions, they may result in acute coronary syndromes. So acute coronary syndromes, it's classified into 3 based on clinical presentation and lab features like cardiac biomarkers, or how high, or if there's the positivity or negativity of your cardiac troponin levels, as well as the presence or absence of ST segment elevation in the standard 12-lead ECG. No, so that's why you classify your coronary syndromes, your acute coronary syndromes, into unstable angina, non-ST elevation MI, and ST elevation MI. No, with severity progressing from unstable to STEMI. So acute infarction or acute myocardial infarction is caused by an acute rupture of your atherosclerotic fibrous cap, which is the most vulnerable part of your atherosclerotic plaque, thereby activating your platelets and the coagulation cascade to result in total occlusion of the coronary blood flow, ultimately resulting in myocardial myocyte death if blood flow is not restored promptly. So after an episode of MI, If the patient survives, the coronary plaque as well as the infarcted myocardium usually undergoes fibrosis. So in ischemia, usually the obstruction is subtotal. In myocardial infarction, the obstruction is total, no 100%. So in acute myocardial infarction like this one, this is the gross specimen of your myocardium. This is your LV, a very hypertrophied left ventricle, and this is your right ventricle. So that's your right ventricular cavity. This is the small slit, and this is your left ventricular cavity. So where's the MI here? Here. This is the thrombosis of your epicardial coronary vessel, and the infarcted myocardium is the yellow necrotic myocardium. Okay, so that's a big infarction. The most common clinical symptom of coronary ischemia is angina pectoris, or myocardial chest pain, which has to be differentiated from your chest pain originating from other structures in the chest, like your costal cartilages, your muscles, your bone, pulmonary structures. They may all mimic pain of myocardial ischemia. So it's very important you becoming later on or someday clinical clinicians. So you have to determine if your patient's chest pain is really angina pectoris or just chest pain originating from outside your myocardium. So the main cause of angina pectoris is oxygen supply and demand mismatch. That is, your oxygen demand becomes higher than can be supplied because there is limited blood flow from your coronary obstruction. So angina is often felt beneath the upper sternum, but it is often referred to distant surface areas like your left arm, your left shoulder, as well as the neck, and even the jaw area in your face. So the reason for this distribution of pain is that during embryonic development, your heart originates in the neck as do the arms. Therefore, both the heart and these surface areas of the body receive pain nerve fibers from the same spinal cord segment. So you refer to that as your referred pain of cardiac origin, no, or referred angina. The subendocardium is often the most frequently infarcted portion of your heart because the endocardium has a higher oxygen consumption and extra difficulty obtaining adequate blood flow because the blood vessels in the subendocardium are intensely compressed during systole. So any condition that compromises blood flow to any area of the heart usually causes damage first in the subendocardial regions, and the damage then spreads outward toward towards the epicardium. So what is the concept of collateral circulation? So normally there are no communicating vessels that connect larger branches of coronary arteries. However, many anastomoses do exist among the smaller arteries, this part, size 20 to 250 micrometers in diameter. So your collateral circulation usually develops as a compensatory response to increase coronary flow in patients with chronic but not totally occlusive obstructions or atherosclerotic plaques. So sort of compensatory mechanisms ni siya. So how do collateral vessels develop? So when a sudden occlusion occurs in one of your larger coronary arteries, your small anastomoses begin to dilate within seconds, thus somehow helping to prevent coronary ischemia. However, your vasodilatory properties of the collateral vessels are usually limited compared to your natural branches. Blood flow through these minute collaterals usually is less than half that needed to keep alive most of your cardiac muscle that they now supply. And the diameters of your collateral vessels do not enlarge much after like 8 to 24 hours. The degree of damage by the heart muscle caused either by slowly developing atherosclerotic constriction of the coronary arteries or by sudden coronary occlusion is determined to a great extent by the degree of collateral circulation that has already developed or that can open within minutes after the occlusion. So if you have developed many collaterals, there's a tendency that you may survive your infarction at that time, compared to an acute occlusion wherein your coronaries have not yet developed collateral circulation. So when atherosclerotic constricts the coronary artery slowly, like over a period of many years, rather than suddenly, your collateral vessels can develop at the same time while the atherosclerotic becomes more and more severe. So therefore, the patient may never experience an acute episode of cardiac dysfunction, or may just develop subacute small infarction that sometimes go unrecognized clinically. But eventually, however, the sclerotic process develops beyond the limits of even your collateral blood supply to provide the needed blood flow. And sometimes also, your collateral vessels themselves can develop atherosclerosis. In coronary angiography, this is how your collateral vessels would look like. So this is your left anterior descending, and this is your left circumflex coronary vessel. So these are small collateral vessels connecting the two. Okay. And this is another coronary angiography image showing significant collateral vessels connecting the left anterior descending. This is the left anterior descending, and this is the left circumflex. And they have many small collateral branches that has already developed. So what are the most common causes of death of decreased cardiac output? This is basically secondary to your systolic stretch or dyskinesia. Example, if you have 40% infarction involving 40% shock would develop. Your systolic stretch, as defined by your book, I think it says like this means stretching of the infarcted segment caused by the relative contraction of the remaining normal myocardium. No, so and then the second cause of death also would be damming of blood in your pulmonary blood vessels, and then death resulting from pulmonary edema. Usually this develops days after. It's because there's a bit of delay of the response of the kidneys, and then you may also develop ventricular fibrillation, usually within the first minutes to 10 minutes or up to the first hour. The causes of fibrillation would be usually increased potassium levels in the extracellular space surrounding your ischemia, as well as your occurrence of injury, like we've discussed in ECG, the effects of your sympathetics, as well as development of a normal conduction pathway and the development of your circus movements in the area of bridge. So this would make the base to develop. So the upper left part of the diagram, this one, shows the effects of your acute coronary occlusion in a patient with a smaller area of muscle ischemia compared to this one, which has a larger infarction. So the red areas of the infarct are the non-salvageable or the dead myocytes. Now you cannot do anything with it. So those are dead myocardium. Now the purple circles are actually what we call your ischemic penumbra. So these are areas of decreased blood flow, but still salvageable areas of your myocardium. So infarction is to save this ischemic penumbra, the purple one. And then the white circles are your tissues are non-contractile tissues. Previous MI before, usually there's the heart has, or the left ventricle usually has many scars developed already, myocardium. Medical, how do you treat MI? In generally, so this is a very complicated topic, but at your level, it's enough to know that there is a medical treatment of MI, usually involving the administration of vasodilator drugs like your nitroglycerin, nitrates, ACE inhibitors, your aldosterone receptor blockers, calcium channel blockers, as well as ranolazine. And you may also give beta-adrenergic blockers to tone down your sympathetics, of course, antiplatelets in order to lessen the propagation of your thrombus, as well as thrombolytics to halt the progression of your coagulation cascade. Aside from medical treatment, which is offered now mostly in tertiary hospitals, you can also do invasive or minimally invasive treatment. You can do coronary angioplasty, wherein you just dilate the obstructed area of the coronaries by inserting a balloon catheter here. So this is the balloon catheter inserted peripherally, either from your radial artery or from the femoral artery. And then once the balloon is in place, it will be dilated for a few seconds, several times, until you produce enough vasodilation to reestablish your lumen. Or if the obstruction really is severe, you may add putting in a coronary stent after enough coronary dilation. No, so this is coronary stenting, and then you leave the stent there forever, no, through the patient's life. Or the last result, if you particularly if the coronary obstruction is involving the left main vessel, or 3 of the coronaries are involved, the best treatment option would be doing a coronary artery bypass graft or your CABG. So what we usually do with bypass is you harvest vessels like a chest artery vessel, and then you reconnect it somewhere in the aorta, and then the distal portion of your graft is connected distal to the obstruction, to the coronary obstruction. So you already know naman where the coronary obstruction by doing an angiography first. So what you are basically doing is bypassing that obstruction by re-establishing new vessels. You can also use your saphenous vein grafts. These are your vein grafts from your legs. So you harvest veins from your legs, and then you graft it in your coronaries. No, so this is our actual patient undergoing a bypass graft. So this is the median sternotomy. Okay, so I have some learning issues for you. What is the importance of rest in patients with MI? No, so you read on coronary seal syndrome. This is mentioned in Guyton. Okay, there's I think 1 or 2 paragraphs lang. And then what would be the expected function of the heart after recovery from your MI? So you read failure. So heart failure can result from any heart condition Guys, sorry, I was disconnected. Where did I end? Where was I disconnected? Which part?
You ended on heart failure, doc. The start of heart failure. You
All right.
mentioned heart failure.
All right. Sorry about that. Let me resume. Okay, so again, your heart failure can result from any condition that reduces the ability of your heart to pump enough blood to meet your body's needs. So the general pathophysia of CHF is caused by decreased contractility of your myocardium resulting from diminished coronary blood flow. However, there are other causes of heart failure not resulting from coronary artery disease. So these are like your valvular heart diseases, no, any form of valvular heart disease, the end stage of any VHD or even congenital heart disease is actually heart failure. And then you also have metabolic disorders like your vitamin deficiency, specifically vitamin B deficiency, causing like beriberi. Primary cardiac muscle disorders, which are primarily genetic disorders, and as well as other disorders that result in a hypoactive myocardium. So clinically, your CHF is classified as CHF with reduced EF versus CHF with preserved EF. So that's what we do in the clinic. So you identify these patients and then you classify them as CHF with reduced EF or CHF with preserved EF, the ejection fraction. Physiologically, which is in Guyton, so it's classified as an acute heart failure and chronic heart failure. And then chronic heart failure can either be compensated or decompensated. Usually, however, both are a spectrum of different disease. So your patient, let's say, had an MI now, then after 5 years, 10 years, especially those patients not maintaining their medications or lost to follow up, they usually develop symptoms of heart failure after 10 years, 15 years. So if they can be maintained or if they are religious with their meds, they are usually maintained for years in a compensated state. However, in the long term, especially if they develop another MI again, they usually go into a decompensated state, which is sort of parang an irreversible stage and intractable symptoms, wherein the only primary treatment would be a heart transplant. Other than that, you can only do so much by giving supportive treatment. So let's start with acute and chronic compensated heart failure. So what are the effects of your moderate cardiac failure? So if the heart suddenly becomes severely damaged, such as by an MI, the pumping ability of your heart is immediately depressed. As a result, two main effects would occur. There will be reduced cardiac output, and there is damming of blood in the veins, resulting in increased venous pressure. So this is a very important graph. So this shows the progressive changes in cardiac output after an MI. So both your cardiac output and your right atrial pressure change progressively from point A to point D, illustrated by the black curve, over a period of seconds, minutes, days to weeks. So in order to compensate or try to return cardiac output to normal, your right atrial pressure must progressively increase, brought about by increasing the right atrial volume. So immediately after the heart becomes damaged, from point A, the cardiac output becomes greatly depressed, falling to the lowest curve at the bottom of the graph, that is your point B. Within a few seconds, a new circulatory state is established at point B, illustrating that the cardiac output has fallen, let's say, to 2 liters per minute, so around 2, which is about 2/5 normal, whereas the right atrial pressure now has risen to +4 or +4 mmHg, because the venous blood returning to the heart from the body is dammed up in the right atrium. And then after point B, your sympathetic reflexes become activated now, which maximal activation would develop in about 30 seconds. 30 seconds because in your book, which is now your point C. Therefore, a person who has a sudden moderate heart attack might experience nothing more than cardiac pain and a few seconds of fainting. And then shortly after 30 seconds or more, with the aid of your sympathetic reflex compensations, the cardiac output may return to a level adequate to sustain the person if he or she remains quiet or rested or even just lying down, although the pain might persist. So this is your point C to point D. So the cardiac output can still be somewhat preserved at the expense of increasing right atrial pressure, which is actually the cause of most of your symptoms related to heart failure, the increasing right atrial pressure. So the best known of the sympathetic nervous system compensatory mechanisms to increase your cardiac output is the baroreceptor reflex, which is activated by diminished arterial pressure. Diminished, yes, diminished arterial pressure. You also have your chemoreceptor reflex, the CNS ischemic response, which we will discuss later on, and even the reflexes that originate itself in the damaged myocardium. Also likely, they are all also likely to contribute to activation of your sympathetics, as well as strengthening of the damaged muscles and increasing your venous return. So after the first few minutes of an acute heart attack, after a prolonged like semi-chronic state begins, characterized mainly by two events. First, retention of fluid by the kidneys, and second, varying degrees of recovery of the heart itself over a period of weeks to months. This is illustrated by the light green curve in this figure, point D. The increased blood volume from your renal fluid retention is actually beneficial if the fluid retention is just moderate. The increased blood volume increases venous return in two ways. First, it increases your mean systemic filling pressure, which increases your, somebody's trying to get in, excuse me, which increases your would come out. Let's go to chronic decompensated heart failure. So if the heart is severely damaged, no amount of compensation, either by the sympathetics or fluid retention by the kidneys, can make the excessively weakened heart pump a normal cardiac output. So the cardiac output cannot rise high enough to make the kidneys excrete normal quantities of fluid. And fluid continues to be retained, thus the patient goes into a positive feedback loop, presenting clinically as worsening peripheral and systemic edema and shortness of breath. So comparing this to the graph that we've just discussed in compensated heart failure, so this is how your decompensated heart failure would look like. So the cardiac output is greatly depressed in decompensated heart failure. There is progressive fluid retention, which raises your right atrial pressure over a period of days to months to years, which results in progressively increasing right atrial pressure and later further sodium calcium exchange pump, which extrudes calcium from the cell in exchange for sodium. Because your sodium calcium pump is relies on a high sodium gradient across the cell membrane, accumulation of sodium inside the cell reduces its activity, thus making calcium more available to facilitate the contractile process. The second option, also the second drug option, which is one of the pillars of medical treatment in symptomatic chronic heart failure, is the administration of potent diuretics, which increases renal excretion of your excess volume. So please take note again of the differences of the graphs in compensated versus decompensated heart failure. So we also have a specific kind of heart failure, which is unilateral left heart failure. So this develops when the left side of the heart fails without concomitant failure of your right. So your mean pulmonary feeling pressure rises because of the shift of large volumes of blood from the systemic circulation into the pulmonary circulation. So usually these are the patients who suffer from an acute large infarction of your left ventricle, thereby decreasing cardiac output suddenly and then raising your left atrial pressure, thus developing severe pulmonary edema within minutes. Usually, kaning makita nato guys ng mga chronic heart failure patients, they are usually biventricular na nga failure. Actually, they are those patients na who survived smaller or even moderate degrees of left ventricular MI na in years, after pila ka years, who develop right-sided heart failure na po because of the left heart na process during the acute MI. But this one is specific, no? It's just as the MI is very large, such that the LA pressure cannot accommodate the sudden increase in pressure and the sudden drop of your cardiac output. That's why pulmonary edema would develop very suddenly. The pulmonary edema in late stage or even in acute heart failure is a lethal positive feedback loop or a vicious cycle. So what happens? So there is a temporarily increased load on the already weak LV, which initiates your vicious cycle. And because of the limited pumping capacity of your left heart, your blood begins to dam in your lungs. And then the increased blood in your lungs elevates your pulmonary capillary pressure, and a small amount of fluid then begins to transudate into the lung tissues and the alveoli. The increased fluid in your lungs diminishes the degree of oxygenation in your blood. And then your hypooxygenation in the blood further weakens the already weak heart, and then it causes peripheral vasodilatation. This peripheral vasodilatation further increases your venous return of the blood from the peripheral circulation. And then the increased venous return further increases damming of blood into the lungs, leading still to more transudation of fluid, more arterial hypooxygenation, more venous return, and so forth. Thus, a vicious cycle has been established. So what can we do? So these are heroic, no, not totally effective, but at least these are the things that you can do if you have a patient with an acute pulmonary edema. So you may put in tourniquets in both arms and legs to at least sequester much of the blood in the veins and therefore decrease workload of the left side of the heart. You may also apply or administer a rapidly acting diuretic. So just be very careful lang with your diuretics like your furosemide because these are very potent. This might drop your blood pressure suddenly, so be careful lang. You can also give pure oxygen for your patients to breathe to reverse your blood hypooxygenation, or you may intubate your patient right away, or you may administer a rapidly acting cardiotonic drugs such as your digitalis to strengthen your heart. Careful lang mo sa digitalis because this might also cause extreme bradycardia, sometimes mga heart blocks, okay? So what is cardiac reserve? Like we've mentioned before. So this is the maximum amount of the maximum percentage that the cardiac output can increase above normal. So in a healthy young adult, you have a 300 to 400% cardiac reserve. If you are athletically trained, you may have as much as 600% of a cardiac reserve. And any factor that prevents the heart from pumping blood satisfactorily will decrease the cardiac reserve. Thus, in heart failure, severe heart failure, there is no cardiac reserve. So this is why the reason why some patients are asymptomatic at rest. But when they exert effort, even minimal effort, their symptoms would appear. This is because they don't have any cardiac reserve left. So showing it graphically, so this is how the variations of the ranges of cardiac reserves in several physiologic and disease states would look like. This is your normal in very athletic person and in disease states. So what is exercise testing? So this is what we do to diagnose a low cardiac reserve secondary from a not totally obstructing coronary obstruction. So this requires the person to exercise either on a treadmill or by walking up and down the steps, either of which modality, treadmill or walking up and down the steps, would increase your cardiac output. The increased load on the heart rapidly uses up the small amount of reserve that is available, and the cardiac output soon fails to rise high enough to sustain the body's new level of activity. That's why at the later stages of your treadmill test, if you really have a significant coronary obstruction, you can see ischemic changes in your ECG, manifesting as ST segment elevation or ST segment depression. So if your stress test is positive, so that's the time wherein you can say that your coronary obstruction is hemodynamically significant. Then that's the time you subject your patient to coronary angiography. Okay. This is what we also usually do to determine if the patient's chest pain is actually coronary in origin or not. Because if it's really significant coronary obstruction, you always have significant ST segment changes during the peak of exercise. Now, during exercise, namin siya stages, like stage 1, stage 2, stage 3, depending on the protocol that you are using. Okay, so that's basically the concept of exercise testing. Any questions so far? Heart failure, before we go to shock. Yan. Okay, circulatory shock. This is my last topic. Dali edit. So circulatory shock means generalized inadequate blood flow through the body to the extent that the bodies and tissues are damaged, especially because too little oxygen and other nutrients are delivered to the tissue cells. So there are many definitions of shock. So one of the definitions is based on the physiological cause of the shock. So you may have a circulatory shock caused by a decrease in cardiac output, or you may have circulatory shock without diminished cardiac output. So what are the kinds of shock caused by decrease in cardiac output? So any condition that reduces the cardiac output far below normal may lead to circulatory shock if not managed right away. So two types of factors can severely reduce your cardiac output. You may have a cardiogenic shock. Now, when you say cardiogenic shock, you really have specific cardiac abnormalities that decrease the ability of the heart to pump blood. So this is the kind of shock in acute myocardial infarction patients. No? And you may also have factors that decrease your venous return. So you have diminished blood volume. Example of this would be an acute hemorrhagic shock, no, because of the acute diminished blood volume. And then you also have decreased vascular tone. The classic example of this would be your neurogenic shock. We'll discuss them all later. And then you also have shock secondary to a mechanical obstruction to your blood flow. So what are the types of shock without decrease in cardiac output? So you may have shock secondary to an excessive metabolic rate, like in your thyroidism, like in your hyperthyroid storm patient, no kaning mga nag-thyroid storm. So they may have episodes of severe hypotension. And then you may have shock secondary to abnormal tissue perfusion patterns. Example of this would be those patients who have significant arteriovenous fistulas. No, parang the mechanism is shunting of blood instead going to the heart, it would go much into your fistula and your shunts. So you develop severe hypotension. So once circulatory shock reaches a critical state of severity, regardless of its initiating cause, the shock itself leads to more shock. So it becomes a rapid positive feedback and a vicious cycle where shock causes more shock, ultimately resulting in death. So what are the stages of shock? So there is the normal circulatory compensatory mechanisms in non-progressive stage, which can eventually cause full recovery without the help of outside therapy. You may have also a shock of a progressive stage and an irreversible stage. The difference lang, Ana, is in progressive stage, if you can catch this patient in that stage and you administer adequate therapy, you may be able to still save the patient. But if you catch this patient in the irreversible stage, no matter how much transfusion you give, these patients will eventually die. Okay, nakaset in naman ang vicious cycle. Let's go first to hypovolemic shock, secondary to acute blood loss, no, or hemorrhagic shock. So this is caused, the mechanism is basically hypovolemia, the diminished blood volume. So this is the graph of hemorrhagic shock, plotting cardiac output against the percent of blood removed. So the red curve is your cardiac output and your blue curve is your arterial pressure. So if you look at it, both of which of course will decrease in time, depending on how much blood is lost. But if you look at the upper part of the blue curve, that one I encircled, that is the arterial pressure is maintained at or near normal levels in the hemorrhaging person longer than the cardiac output, the red curve. No? So your BP can be preserved longer than your cardiac output, no, even at the same amount of bleeding. That is the reason for this actually is that your sympathetic reflexes are more geared towards maintaining arterial pressure than maintaining your cardiac output. No, remember that. So they increase arterial pressure mainly by increasing total peripheral resistance, which has no beneficial effect on your cardiac output. So remember your formula. Your blood pressure is cardiac output times total peripheral resistance. Cardiac output is stroke volume times heart rate. Yes, cardiac output is stroke volume times heart rate. So at around 50 millimeters mercury, there is a second plateau. This one. This results now from activation of your CNS ischemic response. So what is this response? This would, the result of this would be extreme sympathetic stimulation of your sympathetic nervous system when the brain begins to experience lack of oxygen or excessive buildup of carbon dioxide. And then this effect of your CNS ischemic response can be called now your last ditch stand during shock of your sympathetic reflexes and their attempt to increase or to keep your arterial pressure from falling too low. So your sympathetic reflex compensations are the following. So you have three important effects. Number one, they promote arterial vasoconstriction in most parts of the systemic circulation, thereby increasing your TPR. The veins and the venous reservoir also constrict, thereby helping to maintain adequate venous return despite diminished blood volume. And then you also have tachycardia, increasing your heart rate even as high as 180 beats per minute. So what is local blood flow autoregulation? So this is the maintenance of normal arterial pressure even in the presence of decreasing cardiac output. Protection, this is to protect your blood flow through the coronary and cerebral circulation. So usually your coronary and cerebral circulations are preserved even if the rest of your systemic circulation is already depressed. This is brought about a sympathetic stimulation, which does not cause significant constriction of your either cerebral or cardiac vessel. In both of these vascular beds, your local blood flow autoregulation is excellent, which prevents moderate decreases in arterial pressure from significantly depressing their blood flows. Blood flow through the heart and brain is maintained essentially at normal levels for as long as your arterial pressure does not fall below 70. If your blood pressure is fall pagid into, let's say, palpatory 15, then that's the time that you might be having you might develop na mga secondary infarction because of the hypotension or mga secondary stroke. For the non-progressive compensated shock, the factors that cause a person to recover from moderate degrees of shock are all negative feedback control mechanisms of your circulation that attempt to return cardiac output and arterial pressure back to normal levels. So these are the following. We've mentioned most of them naman siguro, basically all. So baroreceptor reflexes, your CNS ischemic response, your reverse stress relaxation of the circulatory system, your increased secretion of your renin, as well as the formation of angiotensin II, increased secretion of your antidiuretic hormone to preserve your blood volume, increased secretion of your epinephrine and norepinephrine, as well as compensatory mechanisms that return blood volume back toward normal. So this is just basically to show the entire progressive shock or vicious cycle. Okay, so decrease in cardiac output would lead to decrease in arterial pressure, thereby decreasing your systemic blood flow. You have three main effects of that. You may have decrease in cardiac nutrition, decrease in nutrition to tissues, and intravascular clotting. So see, decreased cardiac output can actually activate your clotting system. All of this may decrease nutrition to the brain because of the decreased blood flow, and because of that, you would have decreased vasomotor activity, not just in the brain, but systemic, and then systemic vascular dilatation, and then all of which will promote venous blood pooling. Your decreased nutrition also to tissues would lead to decreased nutrition of your vascular system, and there would be exudation of your blood from your capillaries out to your interstitial spaces, further decreasing now your blood volume. Tissue ischemia itself also would release toxins, all of which would further depress your myocardial contractility and decrease your blood volume. No, so vicious cycle. This is what I said before. So if you have a patient already in irreversible shock and then you administer blood, no matter how much blood volume you give via transfusion, you cannot save the patient because a reversible shock has already set in. So the best time to therapy would be here during the very acute stage or during the progressive stage. But once your irreversible stage already sets in, then you cannot do anything actually. So there is generalized cellular deterioration in progressive shock. So whatever the form of shock, either hemorrhagic, neurogenic, or septic even. So this is basically what happens in the cellular level. So there is active transport of your sodium and potassium through your cell membrane, which is greatly diminished. And then the myocardial activity in your liver cells, as well as many other tissues of the body, become severely depressed. Your lysosomes in your cells in widespread tissues begin to break open. No? So there is widespread lysosomal activation with intracellular release of your hydrolases from your lysosomes that cause further intracellular deterioration. And then cellular metabolism of your nutrients, such as your glucose, eventually becomes greatly depressed in the last stages of your shock. So there's also a specific form of hypovolemic shock caused by plasma loss. So what we've discussed is hemorrhagic blood loss. That is loss of red cells and plasma. But there's also a form of shock wherein the primary loss is just plasma volume. So the same characteristic, this has the same characteristic of hemorrhagic shock, except that blood viscosity is greatly increased, no, because you are losing plasma, and the remaining red cells in your circulation now will become very viscous. The clinical conditions usually causing specific hypovolemic shock from plasma loss would be intestinal obstruction. No, as you may later read on, if during your GI, your intestines actually produces large amounts of fluid per day. So if you have obstructions there, there is no way for the reabsorption of fluid. So you would be losing too much fluid or plasma volume. Also in patients with severe burns or other denuding conditions of the skin. And then, of course, your dehydration, secondary to excessive sweating, fluid loss, and severe diarrhea or vomiting, excessive loss of fluid by the kidneys, either from, probably from medications, no, if you are giving too much diuretic, so can also promote that. Inadequate intake of fluids and electrolytes, and destruction of your adrenal cortices, which supplies your aldosterone. Another form of shock is what we call neurogenic shock. So this is the shock that occasionally results from shock without any loss of blood volume. So the mechanism here is overall decrease in vascular tone. No, so we usually see these patients, kaning mga patients who undergo deep general anesthesia, spinal anesthesia, or brain damage. Or sometimes kaning mga acute high spinal cord injury, no, mga cervical neck injury. So they have widespread loss of arterial tone. Thus, your patient will develop neurogenic shock. You also have a kind of shock which is kind of common. We call it your anaphylactic or histamine shock. No, basically allergic shock. So your anaphylaxis is an allergic reaction, the worst form of allergic reaction, in which the cardiac output and arterial pressure often decrease drastically. This results primarily from an antigen-antibody reaction that rapidly occurs after an antigen in which the person is sensitive to enters the circulation. One of the principal effects is to cause the basophils in the blood and the mast cells in the pericapillary tissues to release histamine or other histamine-like substances. The effects of histamine will be widespread venous vasodilatation, arteriolar dilatation, and increased capillary permeability. That's why mag-edema ni sila, mag-urticaria. No, kana muhubag dayon ang face. So that's basically blood vessel na vasodilatation, both venous and arterial. The last form of shock would be septic shock. So this is formerly known as blood poisoning. So this is caused by a widely disseminated bacterial infection causing bacteremia and septicemia. So most are caused by gram-positive, followed by endotoxin-producing gram-negative bacteria. And then other than your cardiogenic shock, it is the most frequent cause of shock-related death in modern hospitals. So what are the typical clinical settings that cause septic shock? So one of which is peritonitis. This is the spread of infection from, let's say, your female genital tract, and then somehow the infection escapes the female genital tract, causing widespread infection of your peritoneal cavity. And then, of course, peritonitis from gastrointestinal rupture. As we all know, your intestines have so many bacteria there. So rupture of any, even microscopic rupture may cause patients to develop septic shock. And then generalized body infection, usually resulting from spread of a skin infection, especially in immunocompromised patients. Common microorganisms would be either strep or your staph. And then generalized gangrenous infection, especially from gas gangrene bacilli. This is what we usually see in kaning mga diabetic foot gangrene. And then you also have urosepsis, wherein you have urinary tract infection progressing into a septic shock. This is commonly seen in the elderly diabetic patients. So what are the special features of septic shock that differs them to the usual forms of shock? Usually in septic shock, there is high fever, okay, inflammatory man siya. And then you often have marked vasodilation throughout the body, especially in the infected tissues. This is also a high cardiac output kind of shock, no, especially in the earlier stages. And then you have also prominence of sludging of your blood caused by red cell agglutination and response to your degenerating tissues. And then this form of shock also is prone to developing DIC, or disseminated intravascular coagulation. So how do we treat shock in general? No, so basically replacement therapy. So what we mean by replacement therapy is in hypovolemic shock. So you replace what you lost. If you have hemorrhagic shock, so you replace blood, whole blood. If you have specific plasma loss, then you replace it by fluids or plasma expanders. No, like what, like Destran solution also, you can give it as a plasma substitute. You can also give sympathomimetic drugs, especially for neurogenic shock, wherein you have widespread loss of your vasomotor tone or vasomotor tone. So the drugs of choice there would be to increase your vasomotor tone. And then, of course, in anaphylactic shock, you can give your antihistamines. Supportive therapy also, you may put your patient head down position or the Trendelenburg position, and then you give oxygen therapy if you have signs of oxygen desaturation. No? So dili automatic na yun hang mahatag og oxygen. So check your oxygen sats, probably if it's 95% or less, then you may start giving oxygen. And some doctors also would give steroids, no? Especially if they are suspecting that adrenal insufficiency is a component of the shock. And then if you really fail to do, or if your patient really did not respond to treatment, so always remember this type of ECG tracing. So these are your circulatory arrest rhythms. So you may have a VTAC or ventricular tachycardia. Ang arrest form lang of VTAC is mag-differ. There are two kinds of VTAC man. So there you may have a stable VTAC wherein you still have a pulse, or you may have a pulseless VTAC. So that's an arrest. And then, of course, ventricular fibrillation and asystole. So circulatory arrest is a condition closely allied to circulatory shock in which all blood flow stops as a result of your cardiac arrest or asystole or ventricular fibrillation. So the immediate intervention would depend on rhythm. So this is now the importance of knowing how to identify rhythms. So if you have ventricular fibrillation, defibrillation to your patient. For asystole or flatline lang siya, then your treatment is only probably epinephrine and just CPR, no, cardiopulmonary resuscitation. In general, if you have more than 5 to 8 minutes of total circulatory arrest, there may be at least some degree of permanent damage in more than half of these patients. And then if your arrest lasts longer than 10 to 15 minutes, then almost always there is already significant permanent destruction of mental power. Actually, there's not in the guidelines that say how long you should stop resuscitation for specific types of patients. Actually, it's your call. Now, for younger patients, you may extend your resuscitation longer. For elderly patients, you may shorten your resuscitation, depending on the comorbidities of the patient, the events at which the arrest happens. So it would be your call as to when to stop your resuscitation management. Okay, so I think it's the end. Any questions, guys? No questions? Okay, if no questions at all, then thank you guys. Start earlier si Dr. Bye guys.
Okay.
Thank
Bye.
you, Doc.
Thank you,
Thank
Doc.
you, Doc.
Okay, we'll start with the review for eicosanoids, the different lipoproteins in the cholesterol. Sige, what are eicosanoids? Sorry. So what are eicosanoids? Hello. Morning.
Eicosanoids, Doc, are 20-chain polyunsaturated fatty acids.
Okay, that mostly came from carbon, 20 carbon, no?
Yes, Doc.
Unsaturated fatty acids. So the table, this is a table from the first bi-monthly topic on lipids. If you can remember this, this shows the different unsaturated fatty acids. And then you remember also this table, you have your carbon 20 arachidonic acid, but you also have your temnodonic and acid. And then also here shown is the linoleic and alpha-linolenic acid. That's also important on where you get your the rest of the eicosanoids. So what are the eicosanoids? What are these eicosanoids that we are talking about? So these are review for tomorrow's exam. And you've been discussing this last week noon pa. Okay. So these are the eicosanoids, the prostaglandins, thromboxanes, leukotrienes, and lipoxenes. Also, you remember that your prostaglandins and your thromboxanes are synthesized or produced through your cyclooxygenase pathway, while your leukotrienes and lipoxenes involves your lipoxygenase pathway. What's the difference between the two? The cyclooxygenase pathway and the lipooxygenase pathway in terms of the products. Any differences?
Doc, for cyclooxygenase, Doc, this will produce your prostaglandins, and then for lipooxygenase, this will produce leukotrienes and your lipoxenes.
Okay, how about the process? Sige, starts with our cyclooxygenase pathway. So do you have to memorize all this, the pathway? So what is important in that pathway? Anyone?
Doc, the importance for the pathway is that both cyclooxygenase and lipooxygenase came from arachidonate, which is from arachidonate. There will be there will separate into two. So you have lipoxygenase and cyclooxygenase. So for this pathway, the importance for this one is after arachidonate, with the help of cyclooxygenase, it will turn into prostaglandin G2 to prostaglandin H2. So for this one, I think Doc, like the parent, it's like the parent prostaglandins, wherein all the other products can be found, is coming from prostaglandin H2, wherein from prostaglandin G2 going to PG8 prostaglandin H2. So from the prostaglandin H2, it will be turned into the prostacyclin, which is prostaglandin I2, and then it will become prostaglandin E2, and then with the help of isomerase, it will become prostaglandin D2 and the thromboxane doc. So besides the prostaglandin H2, where the products came from, we also need to know the synthase doc. We are prostacyclin synthase, which is like after prostaglandin H2, with the help of prostacyclin synthase, it will become prostacyclin or prostaglandin I2. So that is the first important also for the synthase. So after the prostacyclin synthase, the second synthase that is important after prostaglandin H2 is the thromboxane synthase doc, which will turn into thromboxane, especially the thromboxane A2, which will help for the blood clot doc. So I think formula doc, that's the important for the cyclooxygenase pathway.
How about the role of the different, you have the different drugs no shown in the figure. So what does it mean?
It means doc like
Anyone? Sige,
okay.
continue.
I'm sorry, doc.
Yes.
Okay. So it means doc like, for example, as you can see this one at the red negative side. So if, for example, so the reason why the arachidonate, from arachidonate going for, there are two pathways, the arachidonate it will be cyclooxygenase, or if it will go to the lipoxygenase pathway. So if you want to stop the production of prostaglandins and thromboxanes with the help of aspirin, indomethacin, and ibuprofen, it stops the production of the prostaglandins and thromboxanes. So from the start pa lang, before going to the cyclooxygenase pathway, it stops the process. So this is where the the aspirin stops the cyclooxygenase pathway in having the products. So at the bottom, we have thromboxane synthase. So the imidazole stops the formation of thromboxanes doc, which is part of for blood clots doc. So if example,
Okay, so,
yes. Doc.
Okay, anyone? So the difference between prostacyclins and your thromboxane. So their physiologic actions. Is there a difference between the actions of prostacyclin and your thromboxane?
Hello, Doc. Good morning.
Yes, Harvey.
Your thromboxanes actually, Doc, since they are synthesized in platelets, when they are released, it would cause vasoconstriction and platelet aggregation. Wherein our prostacyclins, for example, prostacyclin IPGI2, they were actually produced by our vessel walls. So they are potent inhibitors of platelet aggregation, Doc.
Okay, so they are antagonistic. The roles are antagonistic from each other, no?
Yes, Doc.
Okay, so you remember that as well, because this causes some of the local blood circulatory effects that may cause your myocardial ischemia in your heart vessels. So that's why you can see the role of aspirin there to prevent the formation of your prostacyclins, right? So ibuprofen also, that's anti-inflammatory. So were you able to take mga coxibs, right? Celecoxib, eterocoxib. So they are anti-inflammatory. So they halt or prevent the formations of inflammatory mediators through the cyclooxygenase pathway, right? So your book also mentioned the difference between COX-1 and COX-2. I don't know if I have that slide here. Okay, sige. So you have your COX-1, COX-2, different types of like the enzymes, no? So COX-1, they are constitutively, meaning they are always released by our body, by the cells. While COX-2, they are induced, meaning you have different mediators or inflammatory mediators like mga TNF or cytokines that cause your cyclooxygenase to produce the different prostacyclines. So inducing your COX-2 can produce inflammation. That's why your celecoxibs supposedly can prevent formation both COX-1 and COX-2. But then they turned out specifically COX-2 because they don't want the detrimental effect if you inhibit also COX-1, because COX-1 has some functions for homeostasis. But then it turns out that there are other bad effects towards the body. So what's important is also to take note that your glucocorticoids can suppress your COX-2 pathway. So that's the part where your steroids are important in the control of inflammation in the body. Kinsa may na COVID na diri? Anyone? Wa pa? Or you know of someone na COVID? So part of the control of progression of COVID infection is giving at the right time of corticosteroids to halt the inflammation that cause untoward sequelae for a person with COVID infection. Okay, so this is your lipooxygenase pathway. Can you describe, anyone? Describe the effects, the pathway, the lipooxygenase pathway in producing your leukotrienes and lipoxins. So they are, anyone? Easy naman ang lipoxygenase, di ba? Insertion of oxygen into your arachidonic causing hydroxy.
Hello, Doc.
And then,
I can try this one, Doc.
okay, Queenie.
Yes, Doc. So for lipoxygenases, Doc, it has three types of enzymes which can act on different sites in your arachidonate. So it can act on the in the 5th position, 12th position, or the 15th position of the carbon. So for the formation of your leukotrienes, it's only the 5-lipoxygenase enzyme that can produce your leukotrienes. And then for lipoxins, this can be a combination of the enzymes 5-lipoxygenase and also the 15-lipoxygenase. So for lipooxygenase pathway, this will then produce your leukotrienes and your lipoxins.
Okay. So actually, your cyclooxygenase both uses oxygen, right? Your cyclooxygenase and lipooxygenase. And then, but the insertion of oxygen into the carbon of arachidonic using a specific enzyme, it can give the 5-lipoxygenase, 12-lipoxygenase, or 15. cause of formation of the leukotrienes and lipoxins. But as Queenie mentioned, as shown here, so you have the formation of your leukotrienes from your 5-lipoxygenase, where your lipoxins can be from your leukotriene to your lipoxygenase. I've mentioned also previously, last quarter, that leukotrienes are can cause allergic reaction or even your presentation of bronchial asthma. Okay, so the common drug that can control these reactions, the leukotrienes, are your Montelukast. Okay, see, so these are some of the examples in the effects, physiologic effects of these eicosanoids to the body. Okay, so what does this figure tells you? Anyone?
Hello, Doc. Is this the origins of the 3 groups of the eicosanoids?
Okay, so Carl, can you discuss briefly?
So I don't really know too much. I just know the diagram, but it says that you can obtain group 1 prostanoids and leukotrienes from your diet. And then the origin of your group 2 prostanoids, leukotrienes, and lipoxins are going to be from your membrane phospholipids. And then group 3 would also be from your diet. But group 2 can be obtained from your membrane phospholipids and your diet. So it has 2 origins.
Okay, so your inflammatory are produced from your diet through your linulate or your alpha linulate. Then you produce depending on the groups. So if your linulate, so it is eicosanoid, and then it produces your group 1 prostanoids and then leukotrienes. So meaning any inflammation or allergic reaction in your body can be from what you eat also, right? So these are the different the groupings, because it's stated in your learning objectives, the different groups. But what's important is how they are formed, from where the source of your prostanoids and leukotrienes. Bottom line, basically, from your diet, from linolate, can be converted to arachidonate and then creating the different prostanoids and leukotrienes. Okay, any questions with eicosanoid synthesis? Sorry, yes, formation. My questions for tomorrow are 90% recall, so that you can read more on your physio. Physio is very important for you to understand cardio-wise. Okay, cholesterol synthesis. So there are 5 steps for your cholesterol synthesis. Anyone here who had lipid panels done? MedTech know of lipid panel. So the lipid panel consists of, so my results of the lipid panel. Okay, so what are the 5 steps of cholesterol synthesis?
I could try, Doc.
Sige, John.
So for the cholesterol synthesis, it starts with the biosynthesis of mevalonate. So mevalonate here,
From?
uh, um, okay, from the two two molecules of acetyl CoA, which condenses to form the acetyl CoA.
Can I interrupt you for a while, John? So anyone here knows from where you can get your acetyl CoA? Because this will be a future topic pa. So anyone knows where can you get your acetyl CoA? Hello, anyone? Jaswin. Di na lang po. Sige, di na ako Sorry,
Is it
di
from
na
your
siya.
glucose, Doc?
It's here from your glucose metabolism. So it's one part, no, the breakdown of your glucose. You have your acetyl CoA. Okay, so that you can connect later when you discuss glucose metabolism. Sige, go ahead, John, Mary.
Okay, Doc. So for the biosynthesis of mevalonate, it starts with the two molecules, diba, of the acetyl CoA, which condenses to form the acetyl CoA. Then this would be catalyzed by the enzyme thiolase, Doc. So then the acetyl CoA condenses with another molecule so as to form another molecule, the three, I think that this is the three hydroxyl 3-methyl, or the HMG, coenzyme, yeah, which is catalyzed by HMG CoA synthase, Doc. Then this would be different, Doc, because since there's the cytosolic enzyme HMG CoA synthase, which participates in the cholesterol synthesis, and there's the mitochondrial HMG CoA synthase, which participates in the ketone body synthesis. So yeah,
yes, so that you will have that discussion later pa on the respiratory part. So for you, you'll have the cholesterol synthesis.
Yes, Doc.
Meaning it's compartmentalized, the production of ketones later for energy production and the synthesis of your cholesterol. Okay, continue.
Okay, so for then step 2 would be the formation of isoprenoid units, wherein the mevalonate is phosphorylated sequentially by using the ATP by the three kinases, Doc, which would be the mevalonate kinase, the phosphomevalonate kinase, and the diphosphomevalonate kinase. Then after which there's also decarboxylation brought about by the enzyme diphosphomevalonate decarboxylase of the active isoprenoid unit. Then isopentyl diphosphate then is formed, Doc. That's for the step 2. Then for step 3, that would be the 6 isoprenoid units from squalene. So the product form, which is the isopentyl diphosphate, is isomerized so that there's a shift down of the double bond from the double bond to form dimethyl allyl diphosphate. Then it is then condensed with another molecule of the isopentyl diphosphate to form the 10-carbon intermediate geranyl diphosphate. So upon further condensation with the isopentyl diphosphate, this then forms the farnesyl diphosphate, Doc. Then the two molecules of the farnesyl diphosphate then condense at the diphosphate end to form the squalene, which is the precursor for the synthesis of cholesterol. Then the fourth step, Doc, that would be the formation of kanang lanosterol, wherein the squalene would fold into a structure, thus resembling the steroid nucleus. Then before daw the ring closure occurs, the squalene is converted to the kanang squalene 2,3 epoxide by a mix kanang function of the oxidase in the endoplasmic reticulum. So yeah, so the fourth step is in the endoplasmic reticulum. Then the methyl group of C14 is transferred to C13 and then C8 to C14 as the conduct cyclization occurs, which is then catalyzed by the oxidosqualene cyclase. So that's for step 4. Then for step 5, that would be the formation of cholesterol na, or in the kanang from the lanosterol, it takes place also as well sa conduct sa endoplasmic reticulum, and then it involves the changes of the steroid nucleus and the side chain. So the methyl groups on the C14 and C4 are removed then to form the 14 desmethylanosterol and then to zymosterol. Then the double bond at C8 and C9, right, it moves here to C5 to C6 into, yeah. Then thus forming the desmosterol. Then finally na siya, ang yahang conduct is the double bond sa side chain kay i-reduce. Then ma-produce then si cholesterol. Then the role of conduct triparanol there is to inhibit the formation of cholesterol.
Okay. Sige. So, sorry. So, where is the formation or the synthesis of cholesterol takes place?
Sa conduct sa endoplasmic reticulum, then sa steps 1, 2, 3 kay sa mitochondria.
Okay, so cholesterol synthesis can happen anywhere in the body, no? What's stated in your book, any nucleated cells, you have your cholesterol synthesis. So cholesterol in your body, which is higher, cholesterol in body from your diet or from cholesterol synthesis?
Synthesis is slightly higher, slightly above
than your diet.
Yes,
but it depends also on your if you're in the fed state or you're in your starved state, right? Sige lang. And then mainly I don't know if I have that. Okay, so anyone can discuss how cholesterol synthesis is regulated. So the main enzyme for regulation is actually your HMG-CoA reductase, right? So this is the primary enzyme that is blocked so that cholesterol synthesis is halted. Okay, so what are other factors for the cholesterol synthesis to proceed or to decrease or regulated? Anyone? Anyone here taking a statin? Or you know of your parents taking statins? Wala nag-take? No one is taking statins here? Atorvastatin, simvastatin. Good thing for you. Sige. Mga bata pa mo. Sige. So, statins, what are the act on where? Statins act on the HMG-CoA reductase. But what other factors that can proceed to the formation of cholesterol or to the decrease in the blockage of the synthesis of your cholesterol? Sige, can anyone explain this part?
I'll try it off.
Give one.
So very simply, there's two mechanisms in the regulation of cholesterol synthesis. First would be the modulation of the synthesis of the enzyme itself. And second would be post-translational modifications, which involve adding the phosphorylation of the enzyme. So when it's phosphorylated, as you can see, here, if it's phosphorylated, its activity is reduced. So first, in this lower left-hand corner, it's very simple. When there's an abundance of cholesterol, it represses the transcription of the enzyme HMG-CoA reductase. And it does this by inhibiting the sterol regulatory element binding protein, which is the transcription factor for HMG-CoA reductase. So when there is an abundance of cholesterol, for instance, from the diet, there is the transcription factor is inhibited, and so the transcription of the mRNA for the enzyme is repressed. Therefore, we have less of the enzyme, less activity, less cholesterol synthesis. And yes, and then we move on to insulin and glucagon. So very simply, insulin increases the dephosphorylation of the enzyme. So if it's dephosphorylized, it's more active. So insulin directly increases the activity of the enzyme, therefore increasing the synthesis of cholesterol. And then glucagon, on the other hand, it increases the phosphorylation of the enzyme through this kinases. So when it's phosphorylated, it's less active, so there's less synthesis. So those are the two mechanisms for the regulation of cholesterol synthesis.
Okay, thank you, Vaughn. No questions on that? This one shows you the role of your SREBP in the NSIG. So SRBP causes, anyone? So this is involved in your transcription of your enzyme for cholesterol production. So when this is SRBP is activated by if this is SRBP is activated, so you have production of increased transcription of your HMG-CoAs, your INSIG or insulin related protein. This, when it's bound to SRBP, it makes the SRBP not active, thus it will not produce your transcription of your enzymes for cholesterol synthesis. Okay. Cholesterol transport, we'll deal with that later. Sige, lipid transport and storage. So these are your lipids in the plasma. You have your triacyl glycerols, your phospholipids, your cholesterol with fatty acids or your cholesterol esters, and your free fatty acids. That's mainly transported actually via your albumin. So these are the lipoproteins. Can you describe a lipoprotein, the basic structure of a lipoprotein? Anyone here? So your lipoprotein is amphipathic, no? You have a polar as well as a non-polar core. Usually composed, as you can see, in the cholesterol. And then at the outside, your protein. So protein component of your lipoproteins, this can be your B100, E, C, and B48. And then apoprotein. So example is the B100. ApoB. Okay. So anyone can describe describe the differences between the lipoproteins, the chylomicron, the VLDL, the LDL, and HDL. Ion?
Hi,
Okay, Harvey. Sige.
hi, Doc. These four are actually considered as a major lipoproteins: your chylomicron, VLDL, your HDL, and your low-density lipoprotein. Your chylomicrons are considered as the largest and the least dense because of their ratio. It is actually produced in the intestine from your fatty diets or dietary fats, and they are completely cleared within like 6 to 9 hours postprandial. So it transports the main gist of your chylomicrons is that they actually transport exogenous or dietary triacylglycerols towards the liver, muscles, and for fat deposition. Next, Doc, is your VLDL, or also called as your pre-beta lipoprotein, as based on their electrophoretic mobility. Our VLDL are actually secreted by our liver. So the main purpose of our VLDL is that it would transport endogenous triglycerols rather, from the liver to the muscles, fat depositions, and peripheral tissues. And your HDL, your high density lipoprotein, is considered or called also as your alpha lipoprotein because of their electrophoretic mobility again. So your HDL is considered as the smallest lipoproteins, but however, it is the most dense as compared to your chylomicrons, which is the largest and least dense of the lipoprotein particles. So your HDL is actually produced in the liver and intestine, where in the intestine you could actually see the Harper's, they describe it as like a nascent disc shape, if I'm not mistaken. So the main purpose of HDL is that it would transport your excess cholesterol from the tissues and would return it to the liver. So there would be the concept of reverse cholesterol transport, where HDL maintains the equilibrium of cholesterol in the peripheral cells. Lastly is that we have the low density lipoprotein, or what we call the beta lipoprotein, also called as the bad lipoprotein, and your HDL is also called as the good lipoprotein or the good cholesterol. So your LDL is actually synthesized in the liver as compared to your HDL, which is produced in the liver and intestine. So LDL is actually what we consider as the major end product from the catabolism of VLDL. So yes, Doc. And also, it would also constitute, I think, 50% of the total lipoproteins in the plasma, which would be then considered as the major source of cholesterol for tissues. So the purpose of LDL now is that it would transport your cholesterol to peripheral tissues. So it would carry most of the circulating cholesterol of our body and would then transport cholesterol to hepatic and extrahepatic tissues po.
Okay. Sige. This one. This is VLDL secretion in your liver cells. So just know the process, no, of how your VLDL is secreted. So this is the transport of your LDL from the production of your VLDL from the liver. So, and then it becomes a mature VLDL in the different, this is your extrahepatic tissues, but mainly your lipoprotein lipase is present in your endotheliums. And so it creates or breaks down your triacylglycerol to triacylglycerol to glycerol and to different fatty acids, where your fatty acids are used by your tissues. And then because of the breakdown of your triacylglycerols, then you have your IDL or your VLDL remnant. And then from there, you can have your LDL, as Harvey mentioned. Then there are two ways your LDL can be, the cholesterol in your LDL can be used by your tissues, or it can be incorporated into or accepted by your liver for processing of your cholesterol. And you know already that your ApoC and ApoE of VLDL is from your HDL. Also, some of the cholesterols of your VLDL is accepted by your HDL. So this shows the role of your HDL, able to accept your cholesterol from the tissues. Anyone can explain this one? The meaning of reverse cholesterol, the role of your HDL as a good cholesterol in the body. Why does, when you receive a lipid panel result, you want the HDL to be high, the LDLs, the VLDL, and the triacylglycerol to be low? Anyone can explain? So nakasabot ha ang tanan, the role of HDL as a reverse cholesterol transport, meaning it accepts your cholesterol from your tissues. Okay, so when you accept or read, interpret a lipid panel of a patient, and then lipid panel, you have your cholesterol levels, you have your triacylglycerol levels, you have your VLDL, you have your LDL, you have your HDL levels there. But the patient has high triacylglycerol. What does that mean? Anyone? Anyone? Wala? Triacylglycerol, you can get triacylglycerol from your diet. Diet of what? What does dietary triacylglycerol means? You're eating triacylglycerides. From what form of food or kind of food that can have your triacylglycerols high? Eating, aside from eating fatty foods, what type of macro molecule can you derive your triacylglycerols? Stated in your book, right? From eating carbohydrates, especially those high in fructose and sucrose. So those are a lot of the processed foods that you are eating. So when you advise your patients, you tell them to limit also eating processed foods that you can readily see in the grocery stores. So any questions? Triacylglycerol, as previously mentioned by Harvey, is mainly via your lymphatics in the small intestine, so that it can be distributed to the different tissues in the body for use. And then same with more or less your VLDL. So the triacylglycerol is acted on by your lipoprotein lipase to produce the fatty acids that you need by your different tissues. So you have your remnant chylomicron that's processed by your liver, and then also parts of your cholesterol is incorporated to your HDL as well as the APO C and E. Okay, any questions that you want to clarify? For cholesterol, know the basic 5 steps for cholesterol synthesis and the regulation. Those are the important ones for your cholesterol. And then the eicosanoids, differences between the cyclooxygenase and the lipooxygenase. And then transport mechanism, mainly where it is produced, the different lipoproteins, and then where their products go to, and how are they metabolized. And partly read on the excretion of your cholesterol via your bile. So that's, I think, 1 to 2 paragraphs in the book. So any clarifications? But I suggest you study more. If you have to review, please review more on your cardiophysiology. That's the main bulk of the exam tomorrow, right? Please, please, please understand your cardiophysiology.